So myself, Dr. Ashish Mishra, currently working as assistant professor in the Department of Cardiology at UN Mehta Hospital. So today, in fact, we are going to discuss an echocardiographic assessment of diastolic function with a case-based approach. So we have a case, 66-year female, diabetic hypertensive, symptomatic with class 2 dyspnea. And on initial evaluation, she has normal ECG and normal troponin levels. Also that she has elevated NT-pro-BNP level, and this warrants further assessment. We should keep following conditions in mind, seeing the clinical picture of our case. So conditions which are associated with diastolic dysfunction, which are hypertension, ischemic heart disease, primary myocardial disease in the form of dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and also pericardial pathologies like constrictive pericarditis and cardiac tamponade. Conditions that mimic diastolic dysfunction are pulmonary disease, deconditioning, anemia, thyroid illness, valvular heart disease, and congenital heart disease. So echocardiographic assessment in our case will particularly encompass the following variables, particularly chamber morphology, LV systolic and diastolic function, RV function, valvular pathology, great vessel assessment, assessment for pulmonary veins and vena cava, and pericardium. So this in fact is a comprehensive echocardiographic assessment, and we will particularly focus on the parameters for LV function, particularly LV diastolic function in our case. As we know, diastolic dysfunction carries prognosis as bad as LV systolic dysfunction. These are the typical phases of diastole, which starts with isovolumetric relaxation, then rapid early passive LV filling, then diastasis, and then the atrial contraction, which contributes to the late LV filling. Also, we should know that there are various factors which are influencing the diastolic function of heart. These are typically preload, LV compliance, heart rate, then the active myocardial relaxation, LV geometry, LV dyssynchrony, LV filling pressure, also the interaction with pericardium and the LA, pulmonary veins, and the mitral valve pathologies. So since LV diastolic function is influenced by so many parameters, also we should do an integrated echo assessment which will encompass various parameters for assessment of LV diastolic function. These are left atrial volume index, then the assessment of mitral inflow velocities and pulmonary venous flow with PW, then assessment of early and late mitral annular velocities, and also that we should assess the flow velocity propagation, which is VP, by color flow M mode, and assessment of tricuspid regurgitation jet. None of these parameters should be used in isolation for assessment of LV diastolic function. So now we start with the first variable, which is the left atrial volume index, and it starts with the assessment of assessment in 4-chamber and 2-chamber views, and where we can see that these measurements are taken at end diastole and systole just prior to the opening of mitral valve in 4-chamber and 2-chamber views by excluding the pulmonary veins, and measuring the LV volume should be corrected to the body mass index. An isolated increase in left atrial size is the morphologic expression of chronic diastolic dysfunction. It also reflects both duration and severity of disease. So this is a typical assessment for LAVI with the area length method and also by prolate ellipse method. Now the assessment for IVRT, which is the isovolumetric relaxation time. So the duration of relaxation prior to mitral valve opening is important, and when this relaxation is prolonged, mitral valve opening is delayed and IVRT is increased. And conversely, again, when left atrial pressure is elevated, mitral valve opening will occur earlier and IVRT will be shortened. So typically this is the time frame between the ejection phase and the initiation of E-wave. So the time interval between the ejection time and the initiation of E-wave velocity at mitral inflow is the IVRT. So it is derived using the pulse wave Doppler with obtaining a modified apical 4-chamber view. Sample volume is placed midway between the inflow and outflow areas so that the mitral and aortic flows are captured simultaneously. At least 3 measurements of IVRT should be obtained and averaged. Now, in fact, we move on to the assessment for mitral inflow velocities and deceleration time. So this is again the typical mitral inflow signal where we can see the E wave, A wave, Sometimes we can have an intermediate mid-diastolic wave, which is called as the L wave. And then we have the deceleration time, which starts from the peak of E wave to the baseline. So this is again depicted in the photographic cartoon representation over the diagram. So the technical pulse for mitral inflow velocity is basically it again starts with a apical four-chamber view with color flow imaging for optimal alignment. PW Doppler sample volume, typically 1 to 3 millimeter between the mitral leaflet tips. E wave velocity is basically the peak velocity in early diastole, and if with the ECG getting it corresponds just after the T wave, and A velocity is the peak velocity in late diastole, which again corresponds just after the P wave has ended. So this is the typical sample volume which has been attained within 1 to 3 millimeters of the mitral inflow area, and we can see the E waves, A wave, also the deceleration time from the peak of E wave to the baseline. So these variables are well depicted in this diagram. So we should know also the variables which affect the peak E and A velocity. So peak E velocity depends upon the LA-LV pressure gradient on early diastole, LA pressure, and the LV compliance. And typically peak E velocity is more than the peak A velocity in normal subjects. Peak A velocity depends upon the LV compliance and LA contractile function. So based on the E and A velocity and the E by A ratio, we can in fact grade we can assess the diastolic function and also grade LV diastolic dysfunction. This is a typical algorithm as per the American Society of Echocardiography, and this we will be discussing in detail right at the end of our this assessment of various variables. So if E by A ratio is less than 0.8 with E velocity less than 50 centimeters per second, it denotes grade 1 diastolic dysfunction. E by A ratio more than 2, it depicts grade 3 diastolic dysfunction, and intermediate values between 0.8 to 2 with E velocity more than 50 will need further assessment with other variables. So this is the typical L wave which we were talking. It is an interposed wave between the peak E velocity and the A velocity, and it is also sometimes called as the mid-diastolic mitral flow wave. So it again depicts the presence of the abnormal presence of L wave. Again goes on to depicts delayed relaxation and increased filling pressure. So these are the typical. This is a cartoon depicting the typical E and A velocity and the correlation and how it is utilized in assessing the LV diastolic pattern. So here we can see basically the more E and A ratio, and the ratio being in fact in the normal range. Then we have the grade 1 where we can see the impaired relaxation phase where A is more than the E wave in pseudo normal pattern, or with the grade 2 pattern where we can see that the E and A is same as the normal, but we have to take help of the Valsalva maneuver and bring about the impaired relaxation phase. So grade 2 pattern will reverse it to grade 1 pattern if with Valsalva maneuver. And again we have reversible restrictive phase, which is grade 3, and irreversible restrictive phase, which are again separated based on the Valsalva maneuver. So thus both the patterns of E and A waves and the mitral deceleration time follow a biphasic course as diastolic function worsens. This limits the usefulness of mitral inflow velocities alone in assessment of LV diastolic dysfunction. So this is the application of Valsalva maneuver in assessing the diastolic dysfunction. So in normal subjects, reduction with Valsalva maneuver, reduction in velocity affects both E and A waves to a similar degree, and so that the E by A ratio is almost unchanged. But in pseudo normal state, which is grade 2 diastolic dysfunction, the Valsalva maneuver will change the pattern to one resembling the impaired relaxation pattern by particularly bringing about lowering of the preload, and delayed relaxation pattern is typically unmasked with this maneuver. During Valsalva strain phase, a decrease in EY ratio of more than 50% is again a useful indicator of elevated filling pressures. So the factors that affect the mitral inflow pattern should also be taken into consideration. These are particularly extremes of heart rate, particularly extremes of sinus tachycardia, first degree atrioventricular block, atrial fibrillation, and mitral valve disease in the form of mitral stenosis, mitral regurgitation. Now the another variable which should be looked after is the deceleration time, which is defined as the time interval from the early peak inflow velocity of particularly E wave to the cessation of the rapid early filling phase. So this is the typical deceleration time from the peak of E wave to the baseline. And it typically is normal limits are between 140 to 240 milliseconds, and it is inversely proportional to the chamber stiffness. Now we move on to the mitral annular velocity, which is assessed by the tissue Doppler imaging. So basically, impaired LV relaxation lowers the E dash velocity. Best non-load dependent measure of LV relaxation phase is reflected by the E dash parameter. Abnormal values are particularly septal E dash. Basically, septal E dash is measured by putting the pulse wave Doppler right at the septal annular location of the annular level, and septal E dash less than 7 centimeters per second or lateral E dash less than 10 centimeters per second would reflect abnormal diastolic dysfunction. And in fact, E by E dash ratio, which again reflects the pulmonary capillary wedge pressure or the LV indirect LV filling pressure with a ratio more than 14, would go on to suggest that the presence of LV diastolic dysfunction. So in fact, how we get this E by E dash ratio or the E dash velocity. So basically we start with the 4-chamber view. The sample volume is positioned on the mitral valve annulus just near the insertion point of the mitral valve. E dash should be measured at both septal and lateral locations. Sweep should be set between 50 to 100 centimeters per second, and it should be average for at least 3 consecutive cycles. So this is a typical E dash and A dash velocities, and in fact we should always derive after getting the E dash values E by E dash ratio, which goes on to reflect the which goes on to reflect the LV filling pressures. So normal E by E dash ratio is less than 10, and peak annular velocities in early diastole, which is reflected by E dash, primarily depends on the LV relaxation. When diastolic function is abnormal, E dash is relatively independent of preload. However, when diastolic function is normal, E dash increases with higher filling pressure. So in fact, E by E dash ratio predicts filling pressure in the setting of abnormal diastolic function. Some of the limitations which are associated with the assessment with this assessment technique is E and E dash are obtained from different cardiac cycles and at different times. Age, preload, and systolic function can also affect these parameters. Also, that regional wall motion abnormality, prosthetic mitral valves, annular rings, and significant annular calcification can create technical problems in assessing the E dash velocity. Now we move on to the pulmonary vein flow velocity assessment. And this is a typical pulmonary vein flow assessment where we can see the systolic velocity, peak systolic wave, peak diastolic wave, and the atrial reversal peak velocity. And also that the time interval between the end of diastolic wave to the initiation to the end of atrial reversal wave is called as the atrial reversal duration. So this is again also used for assessment of LV diastolic function. So apical 4-chamber and color flow imaging helps to position the pulse wave Doppler volume position just in fact 5 to 10 millimeter inside the right upper pulmonary vein. And in fact, we should take into consideration that the signal gain is set out to be at the lowest. So S by D ratio is the ratio of the peak antegrade velocities in systole and diastole. Normally S is more than the systolic component is more than the diastolic component. So systolic fraction is defined as the duration of the ratio of systolic to the diastolic time velocity integral. The duration of the retrograde atrial wave, which is the AR duration, increases with increased filling pressure or the left atrial pressure, and the difference between the AR duration and the A wave duration, which we had seen earlier in the E and A velocity durations. In fact, if the difference more than 30 milliseconds again reflects abnormal LV diastolic component and indicates elevated LV filling pressures. So these are the typical patterns where we can see that the diastolic component is gaining prominence. Here the diastolic component is very much prominent in the mitral vein flow inflow velocities. Then also here we can see in fact the total blunting of the systolic component and prominence of the diastolic component. So these are the various patterns of mitral vein flow patterns in progressive diastolic dysfunction. So S by D ratio again is affected by several parameters, and the technical challenges in obtaining in the recordings, age, extremes of heart rate, pulse, PR interval, mitral regurgitation, and systolic function are some of the variables which affect the assessment, accurate assessment of S by D ratio. Mitral inflow Propagation velocity, it is the assessment starts with the by achieving a four chamber view. M mode cursor is placed in the center of the column of the mitral inflow signal as parallel to the flow direction. In fact, we can see this is the apical four chamber view, and placing the M mode color with a color component is placed just at the tip of the mitral inflow, and we assess from the apex to valve configuration of the ventricular diastolic function assessment, where we can see the vertical rapid VP slope. So slope of the early diastolic valve to apex contour. So this is basically valve. This is the valvular side of the mitral annular plane, and this is the apex side basically. So valve to apex contour. This particular slope of this mitral inflow propagation velocity will is termed as the VP. And these are some of the patterns reflected in VP. So basically, this is where we can see the normal VP component with signal more than 50 centimeter per second. And here we can see the almost flattening out of the VP velocity, which denotes severe progressive diastolic dysfunction. So impaired relaxation will show the propagation of blood and thereby reduce the slope of the line, which is the VP. And also indirect parameter E by VP more than 2.5 will again in fact reflect increase LV filling pressures or increase pulmonary capillary wedge pressure. So VP is again affected by various parameters of this. In fact, the important are the ventricular geometry, regional disc synchrony, and systolic, particularly depressed LV function. So of this, now that we have discussed, some of the parameters in fact are very much independent or are less age dependent. So these are E by E dash ratio, change in mitral inflow velocities with Valsalva, and the difference between the AR duration and the A duration. Also, there is a complementary role of speckle tracking and strain imaging and stress echo in the assessment of diastolic dysfunction, which is beyond the discussion of our today's talk. So with the variables, many variables which are utilized in the assessing the LV diastolic function of this, in fact, E by E dash ratio, septal and lateral E dash velocities, E by deceleration time, AR duration difference, AR duration, and the A wave duration difference are very important. And with we should also keep in mind that the septal E dash velocity more than 8, lateral E dash velocity more than 10, and LA volume index less than 34 denotes normal diastolic function. But normal septal and lateral E dash with increased LA volume index would also denote normal diastolic function or the athlete's heart component. And also sometimes we have a underlying situation of pericardial constriction. Of this, when we have altered septal or lateral E dash along with increased LAVI, basically more than 34 ml per meter square, then we have to look out for grading of the LV diastolic component. And depending upon the EA ratio, as what we have discussed earlier, and the deceleration time, we can grade the LV diastolic dysfunction into grade 1, 2, or 3. So diastolic function assessment is particularly important also in presence of atrial fibrillation, and the parameters which are to be relied are particularly the deceleration time, particularly if it is less than 160 milliseconds, it denotes again the LV diastolic dysfunction. And in fact, deceleration time less than 130 milliseconds denotes poor survival in most of the subjects. IVRT less than 65 milliseconds, E by E dash more than 11 are all the are other parameters which are to be relied for assessment of LV diastolic function, particularly when we are dealing in a subset of atrial fibrillation patient. E by E dash ratio to estimate LV filling pressure in mitral valve pathologies is almost unreliable, and in fact, some of the parameters are which make it unreliable are significant mitral valve annular calcification, mitral stenosis, significant mitral regurgitation, and prosthetic mitral valve. So this the presence of these pathologies will again, in fact, hamper our assessment of LV filling pressures. So coming back to our case, in fact, with diabetic hypertensive 66-year female who is symptomatic with class 2 dyspnea and elevated NT-pro-BNP levels, and the typical echocardiographic assessment in our patient has revealed the patient is having parameters which are suggestive of the grade 2 diastolic dysfunction, where E by E ratio is more than 0.5, E by E dash ratio is more than 10, depicting increased LV filling pressures, and also that E by VP ratio is more than 2.5. So taking help of the American Society echocardiographic algorithm, given in our case that we have these parameters which are altered, and in fact, patient has more than, in fact, in fact, patient has all the three variables altered in our case, with E by E dash ratio more than 10, TR velocity more than 2.8, and LA index more than 30 ml per meter square. In fact, all the three criteria are fulfilled in our case, and in fact, we assume that the patient is having, based on this algorithm, patient is having grade 2 diastolic dysfunction with increased LA pressure. And also we have an indirect the biomarker NT-pro-BNP level significantly elevated in our case, which depicts that the patient is symptomatic. The NT-pro-BNP levels are elevated, and also the echocardiographic parameters are in favor of grade 2 diastolic dysfunction. So a clinical diagnosis of diastolic heart failure in our case is arrived, taking into the consideration of the NT-pro-BNP levels and the echocardiographic parameters. So basically, we have diastolic dysfunction grade 2 and symptomatic heart failure in our case. So basically, coming to the end of our talk, the key points: diastolic function and filling pressure are assessed by integrated echo Doppler parameters and correlate well with the symptomatology and the cardiac biomarkers. Recognizing the special situations and limitations of Doppler are also important, particularly situations like atrial fibrillation, extremes of heart rate, high output states, mitral valve pathologies is important when assessing the LV diastolic parameters. Abnormal LV relaxation is one of the first manifestation of diastolic dysfunction. Mitral annulus E' velocity is a clinically reliable parameter for LV relaxation impairment, and E by E' ratio more than 14 is specific for increased LV filling pressures. So this brings to the end of our talk. Thank you.